This is Stephen Holloway again. We're going to be talking about coronary artery disease and complications of a myocardial infarction. Major complications of a myocardial infarction are ventricular dysrhythmias, cardiogenic shock, ventricular aneurysms, and ventricular rupture. Ventricular dysrhythmias are the leading cause of death related to an MI. The most deadly of the cardiac dysrhythmias, of course, are ventricular fibrillation and ventricular tachycardia. Other dysrhythmias that you may see will be AV blocks, whether it be a second-degree AV block, Mobitz type 2, or a complete heart block, a third-degree heart block. All of these can be problems that can lead to other issues with the heart. When we look at dysrhythmias, of course, can cause, basically, when we look at ventricular tachycardia, ventricular fibrillation, a loss of the pumping power of the heart. In these cases, these patients will typically need to be treated for these dysrhythmias. Again, these can be a major complication of the heart. Depending on which area the heart is injured, again, heart blocks can be a problem. The heart blocks can be easily treated with a pacemaker for these patients, but it may require, again, a permanent pacemaker for these patients. Sometimes these blocks, and we'll talk about them more next semester, the AV blocks, second and third degree, will go away after a short period of time. These patients may need transvenous temporary pacing until the time for the heart to heal, but in many cases they're going to require a permanent pacemaker to get through these issues. The other thing that is a problem with this is called cardiogenic shock. Cardiogenic shock, basically shock itself, is a syndrome characterized by inadequate tissue perfusion resulting in impaired cellular metabolism. In other words, basically, with cardiogenic shock, the damage is such to the heart that it cannot effectively pump blood out to the remainder of the body. Because the blood is not getting out to the tissues, you begin to get impaired tissue metabolism. Because of this lack of metabolism, you get the buildup of acids, okay, and these patients will become very acidotic very quickly because of this problem. Not going to spend a whole lot of time on cardiogenic shock. You will be doing more on this as we go along. I actually will load just a quick lecture on cardiogenic shock that will be useful not only this semester but next semester as well. But really, when we look at cardiogenic shock is nothing more than severe congestive heart failure. The heart itself is not pumping, and it's going to depend on which side of the heart is not pumping. Remember, if we're talking left-sided heart failure, we're going to see problems with the lungs. If we're seeing right-sided heart failure, we're going to see problems with the periphery, the peripheral circulation. But really, when we look at cardiogenic shock, the whole heart is not able to pump the blood out. There's not oxygen and nutrition getting out to the cells, which can cause a huge problem for the patients. Treatment of cardiogenic shock could be things such as an intra-aortic balloon pump, which Ms. Lee will talk about as part of 203. Support with pressor agents such as dopamine, dobutamine, neosynephrine, levofed. All of those may be used to support some of this. You're going to have to strengthen the heart, and you may see pressor agents as well as other type agents used on these patients. Now, the other things that you can see, but these are kind of rare, but you may see them, are ventricular aneurysms. When we talk about ventricular aneurysms, it only occurs in about 7% of the patients with heart attacks. More than 80% of the left ventricular aneurysms are located near the apex of the heart. They're often associated with total occlusion of the left anterior descending coronary artery, and then patients who have poor collateral blood supply. Approximately 5 to 10% of the aneurysms are also posterior, and 3/4 of patients with aneurysms have had multivessel coronary artery disease. So these patients typically have severe coronary artery disease, so there's not much collateral circulation. So when there's actual damage to the heart, there's a large area of muscle that dies. When we look at a cross-section of the heart with a ventricular aneurysm, it reveals that the aneurysm on this one basically was through and through the muscle. And what we see is basically the wall itself became very thin because of the necrosis. And you can see here the thickness of the heart muscle. This happens to be in the left ventricle. And you can see that basically because of the necrosis, the wall thinned out. The scar tissue wasn't much, and it wasn't able to hold. So this patient ruptured this aneurysm. When the aneurysm ruptures, or basically ruptures, then you begin to get signs and symptoms of cardiac tamponade with these patients. But typically, when the patients have an aneurysm, this would show up on an echocardiogram as a bulging in the wall. There will be stasis in that aneurysm area, and thrombi can form in there as well. And if the thrombi break loose, then you can have other problems such as stroke or maybe PEs, those type of things, depending on which side of the heart it's located in. But if you think about it, we'll be here in the left ventricle. It's going out and probably going up through the carotids more to the brain area. But again, this is a big problem. Think about how poorly the effectiveness of the pumping of this heart is when you have that large of area that's actually muscle, that's scar tissue and not muscle. So as that begins to pump, all this area is not pumping. So this patient also could be moving toward cardiogenic shock as well. These can rupture. You can see here with the arrow that basically there was a hole developed in this aneurysm. All of this is part of the aneurysm that's here. And basically what happens is because of that weakness. In this patient's case, the myocardial infarction occurred 3 weeks before this, and then another occurred later, which caused even more thinning of that ventricular wall. And because of that thinning of the wall, that aneurysm ruptured, or the ventricle ruptured at that site. Remember, we talked about the time frames that go on with these. Basically, this is one of the things that can happen. Again, not something that happens routinely, but it is something that can happen with these patients. When we look at ventricular rupture, or we look at rupture of the aneurysm, it leads to cardiac tamponade. Now, you need to recognize the 3 classic signs of cardiac tamponade. When we look at the 3 classic signs of cardiac tamponade, we see an elevated CVP. So if this patient has in a pulmonary artery catheter, we'll see an elevation of the CVP readings. These patients will develop JVD. You'll hear muffled heart sounds, and then these patients will have pulsus paradoxus. Other things you're going to see, typically these patients are going to go into shock because the heart can't pump. Think about it as that blood collects in the pericardial sac. The ventricles cannot relax and blood can't get into them. This is where we'll see a dysrhythmia called pulseless electrical activity. You will see an electrical rhythm going across the EKG monitor, but even though there's electrical activity, there can't be mechanical activity with these patients. So you need to be aware that this is one of the things, if we talk about PEE, pulseless electrical activity, this is one of the things that you can see. Treatment for this, basically, you can do a pericardial centesis and pull the blood out, but unless that rupture is repaired, the chances of this patient surviving are small. Again, this is one of the very complicated type things. They can take them back into the OR and try to oversew that rupture. But again, the tissue in that area is very thin, so the chances of that being successful are small. When we look at ventricular rupture, the area we actually see more is in the septal region, the area dividing the ventricles. And we can see a septal rupture. And when we do that, we get a shift in perfusion. If you think about it, we really see a left to right shunt. In other words, blood that's in the left ventricle that should be going out through the aorta to the rest of the body is now part of that is being shunted over to the right side of the heart and being sent back through the systems. In the era before reperfusion therapy, septal rupture complicated 1 to 3% of acute myocardial infarctions. Now that's down to about 0.2%. But as we talked about, these septal ruptures occur more frequently with an anterior MI than any other type, more frequently in females, and tends to affect 60 to 69-year-olds. But the big thing is we have that hole in the septal of the heart, so there's connection between the right and left ventricle, so we're seeing a shift of fluids back over. So we're having decreased output to the body, more fluid being put into the right side of the heart. So we're beginning to see lots of problems as the blood begins to back up now into the lungs because of the failure, really leading to right-sided heart failure as part of this whole process. So ventricular septal rupture, again, is another issue with that. As we look at complications of an MI, typically the most common complication of an MI are dysrhythmias, that being ventricular tachycardia and ventricular fibrillation. We will talk about rhythms in another lecture series, but understand those are treatable. And we as nurses are responsible for monitoring the patients and monitoring the rhythms and being alert to things that might lead to those type issues. So again, complications of the MI typically are dysrhythmias, ventricular rupture, ventricular aneurysms, and ventricular septal ruptures are some of the major complications of an MI. All right, that's all I have on complications of an MI. Good luck. We will be recording some more video in a few moments. Thank you.